this talk is going to just center a little bit around what we sort of mean and what we can offer from a neurogenetic standpoint. A little bit of the role of PCP and some future directions. So as far as an outline, we'll talk a little bit about a case that has a through line, and then the what of neurogenetics, the why, putting genomics and genomic medicine into context, goals of neurogenetics, some recommendations and guidelines that are out there, for which there are a few. We'll talk a little bit about global delay and PCP, because I think that's where a lot of the interplay, or at least in terms of being the front lines, that's where we'll see that a lot of our patients in neurogenetics come from, and their chief complaint. And then we'll talk a little bit about what the treatment landscape looks like. So from a case standpoint, I just like to use this case because I think it's a little bit illustrative of some of the types of cases we might see in neurogenetics that are referred from PCPs. So in this particular case, actually, I had gotten a call about this patient prior to meeting the patient. So the sort of week I was to meet them in my training and in residency, just to let me know that they, felt like there was something here to this child with delays. The course was a bit interesting. So it's a 3-year-old at the time I saw them. She had some progressive ataxia and arm weakness. Initial concerns really were not noted until between 9 and 12 months, with kind of a odd crawl, and then delayed walking, and even when walking at 2 years is a bit unsteady. And then about 2.5 years, they felt like she a little weak, and is her speech a little less clear than we would expect. The PCP had ordered a MRI as well as a sleep study because of some concern for breath holding spells, had the EEG with that as well, and referred to neurology. So we had initially seen her just after 3, and then again, actually, a few months later. It's nice to just look at a couple videos. She's an adorable young girl and had permission from her family to use her videos. But you can see that she's got some significant kind of shoulder girdle weakness, but she's otherwise very happy, interactive, non-encephalopathic. But she's weak in her grip. She's weak in her shoulder girdles in particular. You also can see almost a little bit of the scoliosis that was noted the first time we met her as well. This is a bit of a video of her getting up from lying on the ground. So you'll see, a little after 3, so she's probably 3.5 at this video. Very abnormal way to get up, and you can see how she dangles her arms at her side as well. Her gait was wide-based. Another video of her getting up. So here she's actually able to get up on her own a little bit more normally, but still a wide-based gait, weak at the arms. She has trouble lifting over her head, and that is her throw at 3.5. So in terms of presentation, right, this is a perfect case for someone to be evaluated from a neurogenetic standpoint. I would say she doesn't have a really clear phenotype in a lot of ways, right? She's got some ataxia, some delays across all domains for the most part, save for maybe some cognitive delays where she seems to be on target. And then she's got some weakness, particularly in the proximal upper extremities. And so in terms of where to look and how to go about getting this diagnosis, it can be a bit unclear because her phenotype is somewhat complex, right? The questions we would have is, who do we look to? What's the most efficient way of getting a diagnosis? And what's our urgency here? In this particular case, I think one of the keys about a presentation is it seems kind of like this is a bit progressive, or at least there are symptoms that are stacking over time. New symptoms appearing every several months. So the urgency is is certainly higher in a case like this than other cases where you have more of a sort of a static encephalopathy component. In terms of treatment, so it's always in the back of your mind, is there something here that we can treat, right? Do we have any specific treatments that, a differential that includes a diagnosis that has specific treatments, right, that we want to make sure we get to the bottom of quickly. So as I said, where to begin? So when there are opportunities for neurogenetics clinics, I think that would obviously be my preference as someone who spends a lot of time there. Otherwise, child neurology would be a great initial referral source, right? So in terms of the what of neurogenetics, it certainly is an emerging field at the intersection of neurology and medical genetics. It has some training programs that are popping up across the country, so a good handful or so. Often they are focusing even in subspecialties within child neurology. So there are genetic epilepsy programs or movement disorders that specialize in neurogenetics, and in some cases, neurogenetic programs that specialize in neurodegenerative or neurometabolic conditions. So we're seeing a lot more interest in this in a training and subspecialization standpoint. And then from a clinic standpoint, most large children's clinics have a neurogenetics multidisciplinary clinic that at a minimum has a child neurologist, a neurology genetic counselor, and sometimes a medical geneticist. In general, often genetics is considered to be a diagnostic specialty, but when it comes to neurogenetics, there's a movement towards not only diagnosis, but management and thinking about treatment implications of these diagnoses, or in some cases, a neurogenetics clinic can act a bit as a medical home, as it occasionally does here as well. And then neurogenetics is a source and an inspiration for research. So from a diagnosis standpoint, a lot of gene discovery is done at the level of neurogenetics clinics. And then there is a lot of focus on variant interpretation within these clinics, as well as collaboration with other clinicians and researchers. And then certainly it can lead to patients being referred to clinical trials, knowing that there are just emerging gene-based therapies across the board when it comes to neurologic presentations with genetic underpinnings. So just a plug for our neurogenetic clinic, which is located in Novak. In this clinic, we have usually myself and then our neurology genetic counselor, who's Preeti Kazagador, and we make sure we have enough time to either go through pre-test counseling, but also after diagnosis, a good amount of time to be talking about what the implications of the genetic diagnosis and plan going forward, what kind of patients are seen. So really anyone with a known or suspected neurogenetic diagnosis. We've seen some adults, but obviously our target is children. In terms of common presentations and phenotypes, global delays, autism, intellectual disability, epilepsy, ataxia, brain malformations tend to be the most common. And the referrals, so if referred to pediatric neurology, you can certainly put my name or Preeti's name and neurogenetics, and they will find their way to us. In terms of the why, so why is it important, particularly from a, let's say, a primary care provider standpoint, to know about neurogenetics is, I think, to begin with, knowing that there's just this emerging clinical need, knowing that we are now able to send genetic testing as a first-tier test, whereas in the past, we weren't able to often get this done until after several meetings or well into a diagnostic odyssey. And now it often is seen as our first test for certain conditions. The neurogenetics is, as a specialty and as a clinic, is inspired a bit by the accelerated pace of gene discovery, knowing that within neurology, vast majority of our patients, or at least the chief complaints, have a broad differential where genetics is often high on the list there. And knowing that the number of conditions that we have to know about or be thinking about is expanding year over year. We certainly have an expanding test variety options, both in terms of the sort of types of tests and where to send them, as well as how broad they are. In terms of the need of neurogenetics as a specialty or as a referral location, it certainly also helps that as we are doing more genetic testing, there are more complicated results that come out, and more to be done in terms of sifting through those to decide whether or not they're clinically relevant. To this end, there's a lot of variants of uncertain significance that come out of genetic testing, and having a place where people, families, patients can be seen. And then on top of that, there's certainly a shortage of general medical geneticists. So having other practitioners with some genetic training within subspecialties can be very helpful. And then, of course, there is a genetic counseling imperative when it comes to thinking about testing, and particularly broad testing, or thinking about implications for families. Thinking about just two of these, the accelerated pace of gene discovery certainly puts the importance of neurogenetics in the forefront sort of needs for large children's hospitals and the rest, because as you can see here, we see year over year an increase in the number of genes and genotype-phenotype relationships that are being described. We know that since just the last, say, 10, 15 years, we've been adding more than 200 novel genes to the list of genetic disorders that we know and can describe and diagnose year over year, thanks in large part to the widespread adoption of broad testing with exomes and genomes. Here you can really see that somewhere around 2010, when we made a move from broad next generation large panels to using exomes more regularly, the number of genes that were discovered year over year doubled or tripled. So there's just a lot more to be known, and a lot more disorders that can be diagnosed. In terms of expanding testing options, what we used to be limited to was Fragile X, and chromosomal microarray, and karyotypes, and occasional single gene testing. And now we, for even a fraction of the cost of what those tests used to be 5, 10, 15 years ago, we are able to send broad testing, including whole exomes and whole genomes on a clinical basis. Though, of course, these require a bit more in terms of pre and post-test counseling, and often a lot more thoughtfulness given to the uncertainty of some of the results that may come back, right? So it's all very exciting. And there is a lot to be learned out there, and a lot to be done, but a lot of opportunity as well. In terms of goals of genetic testing, or in this case, the goals of neurogenetics, I think it's important to sort of understand what our role can be and where we can help. So one of the main things that is a source of referral in terms of types of patients we see, but also one of our main goals is going to be, let's try to find an answer, right? Let's give some closure to families who haven't been able to get answers despite a long odyssey. Can we inform prognosis? That is, can we predict the future? Usually a genetic test isn't a crystal ball, but having a diagnosis can certainly limit some of that uncertainty, and occasionally narrow a bit of our expectations in terms of prognosis. We hope to enable earlier recognition and earlier intervention about disease and disorder, maybe allow for some disease modification going forward. Resource allocation. So when we think about neurogenetics, if we're able to get an answer, we often can make sure that we are thinking about appropriate additional testing and or evaluations, referrals, and all the rest. Often is part of our goal, and one of the themes of our clinic is, how do we restore some loss of control for families who feel a bit out to sea in terms of their child and the sort of mystery around their diagnosis or why they have some of the struggles they do. And this restoration of loss of control is both for families, but also for providers who have been following these families for years. Also, the determination of risk recurrence and family planning is a primary goal of our clinics and one of the main sources of referrals. Frequently getting an answer allows for families to seek and find connections with other rare disease groups and patient advocacy groups. Neurogenetics clinics, hopefully we are able to work with, inspire, and kind of facilitate in terms of rare disease knowledge and diagnosis and treatment. And then the real pinnacle here is how does our clinic and how do our diagnoses really guide management, right? So, and we often see in a large fraction of patients we see, having a diagnosis helps us determine what's an appropriate or inappropriate therapy. We often are informed about what would be the next step in terms of evaluations or referrals, let's say to cardiology or pulmonology or something of that nature. And then if we are able to find a condition that's either common and we know a lot about or life-limiting, then that can be helpful for families. And then thinking about the comorbidities that we otherwise wouldn't have known about is a frequent finding as well. And then, and of course, thinking about precision medicine is always sort of a new goal in terms of making these diagnoses and the next step in terms of therapy. So Neurogenetics and the PCP. So obviously, in this case, the primary care provider is the front line. Really, the initial evaluation is done there, and then often the source of all referrals to our neurology practice one, as well as our neurogenetics, or previously, most of these patients also were seen by medical genetics, but in this particular case, when there are opportunities for neurogenetics clinics, we can sometimes combine those evaluations into one. So when to consider genetic testing. So if there's a specific diagnosis of suspected, let's say Rett or Angelman or something of that nature, that would obviously prompt specific testing. If there's a positive family history, something that runs in the family, that would certainly provoke a testing. If there are physical exam findings that would suggest a genetic etiology, or that genetic testing would be the next step. Or if there's a progressive course, if you're seeing developmental regression or something like that, I think that would be one particularly time-sensitive time to be thinking about broader evaluations, including genetic testing. So the primary care provider obviously is a source of our referrals, but also the question is that also the appropriate place to start genetic testing? And so actually the guidelines here, they're a bit few and far between and not actually always clear. Though there are a lot of stakeholders and professional societies that have some recommendations that bear on the role of primary care provider and genetic testing. Some of it's just about timing. That is, when would be the appropriate timing depending on the age of a child, for example, or ethics around testing for certain conditions, let's say Huntington's. There's some recommendations about disease or phenotype specific testing. So in this case, global developmental delay is probably the most relevant. And then carrier and pre-symptomatic testing is the place where we have some recommendations and guidelines. Some of the relevant stakeholders include, or professional societies include the AAP, as well as Child Neuro Society, the AAN, and things of that nature. So thinking about global developmental delay, I think this is really where primary care providers are going to be the first person to decide whether or not someone may need additional evaluation, including genetic testing. It's important to just know our terms here. So just as a review, right, when we think about developmental delay, we're usually speaking of some child up to age of 5. After that point, we usually start to use a term of intellectual disability with a history of developmental delays or something along those lines. In this particular case, we're thinking about delays that are more than 2 standard deviations off of what the expectations is. And depending on context, that may look something like they're 6 months behind what the expected milestones might look like. So developmental delays can either be domain specific, or they can be global being defined just as 2 or more domains, and they can be across motor, speech, cognition, social, or function, including activities of daily living. The incidence of global delay and intellectual disability is thought to be about 1 to 3%, although there's some dispute as to if that's an accurate reflection of the incidence. And then there are hundreds of genes linked to global delays and intellectual disability. Not all of them are validated. There's panels that range from 300 to over 2,000 genes. And so the number of genes that we think of as being associated with global delays is expanding, honestly, month over month, from just a handful of years ago. Recommendations for panels included up to 100 or so genes, and nowadays the smallest panel is usually 200 to 300 genes. So in terms of recommendations and guidelines for genetic evaluations, in terms of global developmental delay, they often are a bit confusing, have a lot of arrows and boxes and things of that nature, and occasionally are directed to any provider, including pediatricians, family practitioners, or child neurologists, but can be a bit confusing, and often we find that pediatricians are not as comfortable about sending specific genetic testing, or in some cases, insurance is not super keen on approving it. So this would be one example. This on the left is another example of an algorithm. On the right is the third example of a different algorithm from a different professional society. In terms of distilling what I think would be a fairly reasonable approach from a primary care setting, in general, if seeing a child with global delays, so 2 or more domains with significant delays, then thinking about at least the referral to neuro and checking lead, CK, hearing, or vision, if any of those are concerned. And then depending on the level of concern or comfort level, EEG is frequently recommended if seizures are suspected. And then the chromosomal microarray and Fragile X are, and historically have been, the first line test, although this is changing a little. Neuroimaging is indicated, particularly if there's micro or macrocephaly. And then in terms of second tier type of testing, usually reserved for neurologists, geneticists, and things of that nature. We're thinking about large panels or whole exome, whole genome. Whole exome and whole genome really are emerging as potentially replacing some of our traditional first-line genetic testing options, right? So traditionally, we thought about doing chromosomal microarrays, karyotypes, Fragile X, sometimes some neurometabolic labs early, but combined, those often only get about a yield of 5 to 10, at most about 14% when doing all 3. Whereas large gene panels have yields usually between 10 and 20%. And then exomes and genomes now are getting up to 40, 50%, particularly if you're able to do trios, that is panel exomes and genomes where you're including both parents. So because of the yields are so much greater and the price of doing broad testing has gone down, there's been this consensus to flip a little bit of this on its head and offer whole exome or genome as a potentially a first-line test in children with global developmental delays or intellectual disability, or those with congenital anomalies. So the rub here, of course, is that in order to send this type of testing, you frequently need to find a clinic practitioner, a specialist who is able to consent and order it. And that is where neurogenetics clinics often come in. So this would be one of the thoughts in terms of where the future of evaluations for global delays will look like, is starting with whole exome and then from there deciding potentially on additional testing that might have been missed by whole exome. Right? So you start with a test that might give you your answer up to half the time if done in trio, and then save the other smaller and lower yield tests for if the exome is negative. So now just turning back to the case that we brought up, the 3-year-old with the weakness and ataxia, she eventually was sent for broad testing, which found 2 changes in SLC 5282, which is associated with riboflavin transporter deficiency neuropathy, which is one of the main transporters of riboflavin from the gut to the serum to the CNS, right? So in these particular cases, the CNS is starved for riboflavin because the main transporter is not working. Features tend to be sensory neural hearing loss, muscle weakness that are progressive, ataxia, and then in severe cases, respiratory compromise, muscle wasting, and things of that nature. As a little bit of a cartoon of how we think about transporters, you can see there's 3 main transporters. The RFVT2 transporter is the main transporter that allows for riboflavin to enter the CNS. And without a working transporter, you are left to treating with very high dose riboflavin to try to overcome the lack of efficient riboflavin transporter in the CNS. So in this case, giving supplementation up to 80 mg per kg per day, usually divided over 3 or 4 doses. And the vast majority of children diagnosed properly do see some improvements in terms of strength, mobility, and things of that nature. And they found early, we think can avoid deaths, though over half of untreated patients reported to date have died, those being the ones that were not diagnosed on time. So this is actually a follow-up of somewhere a little more than 6 months after introducing therapy. She's still as adorable as ever. She's still quite symptomatic, but she actually did make some gains in terms of strength and things of that nature. She can lift her hands above her shoulders and head in a way that she couldn't in the preceding 6 months. So she's seen some improvement there. She still has this ataxic gait, but is much more stable, falls a little bit less. You can see here, she's able to lift her hands straight up above her head, which is something she was not able to do before treatment was started. And just another video of her, seeing her kind of walk, bend over, get up, throw a ball. Certainly more coordinated in terms of that than she was previously. So while still not normal, she's made a great deal of progress, owing in part to having a diagnosis and starting on a targeted treatment, right? Even in this case, if it's essentially a vitamin, right? So when we think about neurogenetics, in the back of our mind, we're always wondering, is this diagnosis going to change the outcome, right? The hot term nowadays is precision therapies or precision medicine, which is pretty vague, and there's actually not a formal definition. In general, we think of it as being diagnosis or gene specific, maybe as simple as influence in medication choices. It may be disease modifying, that is, that it's not just symptomatic, but actually targeting the underlying pathophysiology. We hope that this type of therapy is going to modulate the course or change the outcome. And with earlier diagnosis, we often have better outcomes. This is something that's not totally new in the world of neurology, but with more accessibility in terms of genetic testing, we can get to these therapies often earlier and hopefully help outcomes. So just thinking of pediatric movement disorders, all of these syndromes have some degree of what we might consider to be precision medicine, right? Everything from GLUT1 deficiency, where it's really a glucose transporter deficiency, where you can do a ketogenic diet, to ADCY5, where sometimes adding a bit of caffeine can be really helpful in terms of symptoms. The last thing I was just going to highlight was gene-based therapies, because this is really one of the hopes in terms of future treatment possibilities in child neurology. When we think about gene-based therapies, there's lots of different strategies, including gene replacement. So this is often where you think about viruses, like the AAV vectors that can actually just put a gene back into the cell. Gene editing, so this is often where you think about CRISPR. Protein replacement, so where you can add an enzyme back, like in Batten disease. Gene read-through drugs, ASOs. So there's lots of different ways of getting to gene-based therapies. And some have really revolutionized how we approach certain conditions in child neurology, particularly spinal muscular atrophy. So we have now several FDA-approved gene-based therapies in child neurology, including SMA, Duchenne, and as of this month, cerebral X-linked adrenoleukodystrophy. There are also some out there for beta thal, sickle cell, retinal dystrophies, cancers, and immunodeficiencies. And there are more in the pipeline. Just thinking about genetic epilepsy, all of these conditions have current or ongoing clinical trials at various stages for gene-based therapies. So it's certainly going to be the future that we'll be thinking about more opportunities for targeted treatment, and where earlier diagnosis is going to hopefully modulate the outcome. So in summary, genomic technology is influencing all medical specialties, from neurology to primary care to oncology, cardiology, and all the relevant ones. Neurogenetics is a field that's really taking off. I think in terms of what's the biggest black box in human physiology, I think the brain still is the winner there. In terms of how we're, where we are in position of the knowledge to be gained, I think neurogenetics is a place where we've learned the most in the last 5 years, but also where we now have more unknowns than ever before it. The diagnostic yields of our testing are improving annually, and then precision and gene-based therapies are expanding all around us. And in this case, time is often brain, and this diagnostic odyssey often starts at our primary care providers. So we are always happy to take on new consults and things of that nature. So thanks.
Perfect. Thanks so much, Dr. Rock. That was a great talk. Neurogenetics is definitely on the future of neurology. I think there's a question for the general pediatrician in the cases where there is moderate global delays and the wait for developmental pediatric is more than a year. In addition to referral to therapists, is there a tier 1 genetic test you recommend a PCP to order?
So some of this is a little bit of a comfort level. It's a really great question. As you can see, there's not a lot of direct guidelines by the AAP, and rather most of the guidelines are from, ACMG or Child Neuro Society. But there are out there in different professional societies, like the Canadian Pediatric Society has guidelines and recommendations. But it still is considered that things like the chromosome marker A and Fragile X are first line. As I indicated, sometimes even the most helpful things is make sure we have checked some of the non-genetic causes first. So when there are risk factors for lead exposure or thyroid disease and things of that nature, having checked those already can be helpful so that when they do finally see a neurologist, we won't have to be thinking about checking things like that. If there's weakness, I think CK, if there's speech, making sure we have speech delays, making sure we've had audiology evaluations are always important. But in terms of genetic testing, right now, in terms of what is likely to be approved and what is still considered among first-tier testing, chromosome-like array and Fragile X, having those already performed by the time they see neurology can be pretty helpful. That will depend a little bit on comfort level in terms of if you get a result back, that might force families to wait a little bit longer. That is, they may be sitting with that diagnosis for months before they see a child neurologist. If there's something really important, on the other hand, that is found, then you can always reach out, and usually we are able to get someone in. Our waitlist in our Neurogenetics clinic right now is on a couple months, but we actually are pretty good about getting triaging and getting patients who need to be seen pretty quickly, sometimes within weeks.